Welcome to this month's edition of our monthly International Tumor Board from the Tyro Multidisciplinary Seminar Series. We were talking before everybody came online, the panelists, this is one of our favorite things to do each month, to review these cases and learn from each other and teach. This morning, we've got Dr. LaGreca from University of Colorado that'll be presenting the cases. Before we start, let's go around our panelists just here in order and have each of you introduce yourself. I'm Mike Tuttle. I'm the Chief of Endocrinology at Memorial Sloan Kettering in New York. Mark?
Mark Zafereo. I'm a head and neck surgeon at MD Anderson Cancer Center in Houston. Good morning.
And Munir?
Hi, I'm Munir Ghesani. I am a nuclear medicine physician at Mount Sinai Health System in New York.
Erik?
I'm Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital, Harvard Medical School.
Azita?
Radiologist, Mount Sinai, New York.
Zubair?
Pathologist at University of Pennsylvania Medical Center in Philadelphia.
Fantastic. And Frank?
Frank Worden, medical oncologist at the Rogel Cancer Center at the University of Michigan.
Fantastic. Dr. LaGreca, we'll let you multitask, introduce yourself, and go ahead and bring your slides up.
Okay, good morning, everyone. I'm Amanda LaGreca, faculty at the University of Colorado. I'm an endocrinologist and specialist on thyroid cancer. So this is a 51-year-old woman who noticed a lump on her right neck. It's more in a supraclavicular area than on the right lateral neck. She denies any neck compressive symptoms. She doesn't have any changes on her voice. She feels completely asymptomatic. And on exam, she has this right supraclavicular firm 3-centimeter mass, well circumscribed. It's palpable and visible. So here's a picture of her first CT scan showing the 3.4 by 3.2 right supraclavicular mass.
Azita, any thoughts on this?
It looks like she has central compartment and lateral compartment lymph nodes. It's heterogeneous. It's in the right location. So we'll be very suspicious for thyroid carcinoma.
Anything else we should be looking at? I mean, this is a thyroid conference and everything is going to be thyroid. What else goes through your mind with that, Azita?
You know, the central compartment sort of makes it more thyroid, but, you know, you always have to be suspicious when you have a really enlarged lymph node of lymphoma. They're generally more homogeneous, which this one image shows is more homogeneous. You always have to be aware of metastatic neck node from aerodigestive tract. The other thing in the supraclavicular region, one of the things that we think about it less because we all do ENT is Vercal nodes from GI malignancies.
Perfect. Very good. And Amanda, I assume you went for a biopsy here?
Yeah, so she had a biopsy of that mass and it was papillary thyroid carcinoma.
Okay, so show us your imaging now.
Okay, so here is the ultrasound of this patient. And the top two pictures are the right lateral neck, and the top bottom is a left inferior thyroid nodule.
Erik, any thoughts on this? Do you do your own ultrasounds or radiology does them? How do you do that?
We do it together with radiology, often in the same room. But I think the importance here is acknowledging, surgical resection will be an important part of this patient's therapy likely ahead. And so mapping this out, giving them the best evidence of kind of where we see disease is going to be important.
Okay. All right. And then I assume we did more than just the ultrasound, right, Amanda?
So she had some showing here. The center picture is her CT scan. She has sub-centimeter pulmonary. I don't know if you want the radiologist to comment.
Azita, I mean, this is always never fair to show you pictures.
Sure. No.
No
problem. So the patient looks like not only they have a small nodule, at least in that one image in their lung, so it makes it suspicious for metastatic disease to the lung, but there's matted mediastinal lymph nodes. This is more than level 7. This is going throughout the mediastinum from what I could say on the coronal image. In addition, there is on the far right image, anterior to the trachea, there is an additional central compartment. So it's bilateral central compartment, lateral compartment on the right. Once you have one, it's all lateral compartment. And what's worrisome is mediastinal and probable metastatic lung.
Zubair, anything else I need to be thinking about now? We've got sort of a biopsy of a supraclavicular lymph node that says papillary cancer. With all of this, are you thinking anything different or just papillary?
No, papillary, I will be worried about it. It's one of these aggressive subtypes, but it can also happen with the classic subtypes. So the way it's presenting in the lymph node, most likely it's going to be the tumor which is forming papillae with a beautiful nuclei, because cytology was able to outright call it papillary thyroid carcinoma. So at this point, I mean, the size of the nodule in the thyroid and that lymph node. So I will be at the papillary, and I will, what cytologists said.
So Erik, before we send this off to Dr. Zafereo, the endocrinologists often have done this workup, right? The ultrasound, the CT scans, thyroid cancer is the one to have. You just do a surgery, everything is fine. How do you set up? Yeah, you got to go see Dr. Zafereo, but what's he likely to say? How do you frame that?
Yeah, I mean, a new diagnosis of cancer is not an easy thing for anyone, whether it's low, intermediate, or high risk. And I think that should be approached with that kind of candor. This is pretty extensive disease, and I think the key from the endocrine standpoint is you don't really know what you don't know. And while some people do have extensive neck disease, and that's all it is, and they do fine, certainly some people have distant disease, and in those rare cases, it can kind of go south pretty quickly.
So concerns with all of the lymph nodes in the neck that there may be distant as well wouldn't surprise us, right? Mark, this is coming to you. Just from a real practical standpoint, what are you going to tell this patient and their family about surgery? You get a few minutes because this is a couple minutes sort of discussion here in terms of not only the surgery that you're thinking about, complications, expectations. How do you frame this on that initial visit with them, Mark?
Sure. Well, I think the appropriate workup has been done, which is a CT neck and chest. And then I would, talk about sort of the surgery in a stepwise fashion. I mean, we'd obviously need to do a total thyroidectomy. We would need to do a central compartment dissection here. And that includes sort of resection of these superior mediastinal lymph nodes. And then the patient also needs a right lateral neck dissection. I'm assuming the lymph nodes in the left lateral neck are clear on the ultrasound. So, that surgery may be about a 5-hour surgery, sometimes a little more, sometimes a little less. And, we talk about sequentially sort of the risks of thyroid surgery, of course. We talk about the nerves and the parathyroid glands, and then we talk about how the central compartment disease, this bulky central compartment disease, adds to that a little bit. This disease looks more bulky than invasive. So I think that the important structures there, the nerve, there may be some adherence to these lymph nodes, but I doubt that they would be actually involving the nerve. So it requires often some meticulous nerve dissection, but hopefully no invasion. But certainly those issues would be discussed, and then may have to implant the lower parathyroid glands. We really want to try to identify those parathyroid glands. Oftentimes they're in the thyroothymic ligament. Sometimes we can mobilize them out of the way. Sometimes we have to auto transplant them. So the patient should be aware that at least temporary hypocalcemia, temporary hypoparathyroidism risk is high here. And then the lateral neck surgery, there's risks with that. We often have those patients see physical therapy afterwards for shoulder and neck exercises. So I would typically tell a patient like this they may need 3 weeks off. The only other issue, the last issue to be discussed here, and it's not clearly apparent from these images, is really how low that mediastinal disease goes, because if a lot of times this disease can be removed transcervically, and certainly we should always make an attempt to do that. But there are cases where if that disease goes below the innominate vein, we just can't reach that through the neck, and then we have to have our thoracic colleagues involved. Sometimes it's not clear up front, and you have thoracic surgery on standby. This is discussed with the patient. Of course, if you're not able to get the disease out through the neck, you have to do what's called a median sternotomy, open up the sternum to get that disease out. In this case, again, I don't think it's the invasiveness, but of the disease. But if there are some lymph nodes below the innominate vein, that could be a bit of a challenge, and you may need sternotomy here as well. So those are some of the brief considerations here.
So Amanda, welcome to my panel. You get to present and answer questions too. What do you set up the expectation for this patient? He's going to surgery, he's seeing one of the best surgeons in the planet. Is the thyroidectomy going to be 0 afterwards? Is he going to be cured? Are we going to have things to watch? How do you set up what to expect even before Mark goes in and do the surgery?
Yeah, I think he touched on most of the things that we asked the patient. This case was discussed with CT surgery, and because of the extension of this into the mediastinum. So we told the patient that this was going to be a long operation and maybe a long recovery too, compared to most of the thyroid surgeries. And then that we would, investigate more about, we did more of the workup for metastatic disease, but initially she only had a chest CT and a neck CT. And she gets transfers to us with this workup.
Okay.
So yeah.
Okay, so that's where we start. All right. And then so show us what happened with the surgery.
Okay. So indeed she had a total thyroidectomy, bilateral central neck dissection, a right modified neck dissection, and a median sternotomy and a mediastinal mass resection. So I just put some of the pictures that the surgeon sent me, but I think it's very interesting that the primary tumor was 0.5 millimeter PTC with no extrathyroid extension and no lymphovascular invasion. And remember that on the first ultrasound, she did have a left inferior thyroid nodule of 2.3 centimeters, but that lesion was benign. And she has 35 out of 57 lymph nodes with metastatic PTC, and the largest was 2.6 centimeters, and she had external extension as expected. Level 6, 7 out of 10, right level 2, no lymph nodes, right lateral net 18 out of 21, and level 7, 4 out of 4 of 2.6 centimeters. And the remaining thyroid parenchyma had mild chronic inflammation.
Zubair, what the heck is going on here? Because I've been telling the world papillary microcarcinomas are no big deal. Watch them, no problem. Dr. LaGreca knows that. That's why she presents these cases. What up with a papillary microcarcinoma and 1 million lymph nodes?
So, that's why in the new WHO, there's a strong recommendation not to use the term microcarcinoma, because it always kind of reflects that there's nothing is going to happen to the patient, because 25% or more of us walking around with one, right? But, I always say in pathology, never say never. So, you are going to come across a case like this. This case to me is a little bit surprising, because I have seen some of these cases, and in those, you do see like pseudomatous calcifications within the lymphatics, and you see a lot of this permeation. And all the cases that I've seen also have chronic lymphocytic thyroiditis. We also know that sometimes the presentation is a distant metastasis, like a bone mat. And then you go into the thyroid, you basically put the whole thyroid under the glass, and you find just one microcarcinoma. And if you are a little bit unlucky, you may just find a little scar with one kind of papilla in it. So we have all seen, these cases. They are not common cases. And I'm really, for this to me, that many lymph nodes, has been reported, and it does happen. And I'm sure all of you have seen it. But no LVI, no extrathyroid extension. So that is kind of a surprising for this tumor. I don't know what subtype it was, whether it was a tall cell, but already it has shown that this tumor has got out of the thyroid, and has even caused mets to a lung. So we all seen it, but very rare.
I agree. And Amanda, you had at least some molecular testing on it towards the point.
I also wanted to mention this, Mike, since you said about the microcarcinoma.
Yeah.
I don't want to scare the audience to stop doing surveillance of microcarcinomas. Typically, the ones that are aggressive present this way, and these are not obviously tumors that you're going to watch. Correct. So just to keep your business alive.
Strong work.
So she had a molecular pathology done on her tumor, and she had a BRAF V600E mutation.
Which would be consistent with Zubair's field if there was something more going on. This
Right.
may behave more like a tall cell or something like that.
Right.
So post-op, Yep, go ahead. Post-op, where do we go?
Okay. So post-op, this is her first TG, about 6 weeks after surgery. It was 846 with no evidence of TG antibodies and a TSH of 0.45. And at this point, we're thinking about giving this patient radioactive iodine, and we do a brain MRI, and we did not find any brain mets.
Yeah, I mean, I think that's very reasonable in this setting of lots of lymph nodes, potentially distant mets, high TG, to always remember the brain and to look
Right.
at that. Munir, we're headed towards you for radioactive iodine. Is it going to work? Is it not going to work? What's going to go on here?
Yeah, so that's interesting. There are studies that show that these BRAF V600E mutations may have a variable degree of iodine uptake, but it is not all or none. We have seen the examples where despite the mutation, there is significant uptake. And there are other examples where there is no uptake even in the known site. So at least it's worth pursuing the scan first and see what kind of symporter expression is there on the cell surface by looking at the degree of uptake.
Yeah, because there's definitely a subset of these tall cells that grab onto radioactive iodine. Whether
Right.
they
And we also have a couple of sites that are not removed, including the lung nodules. So we have certain target sites that will allow us to see the expression.
Okay, so Amanda, I'm sure got
Yeah.
radioactive iodine.
Of course, she got 150 milligrams of iodine 131, and these are her post-therapy images.
Munir, what do you think? This looks like there's a storm coming in from the East Coast to me. That's what this looks like.
Yeah.
To you, what
And
does this look like?
Yeah, so quite a high degree of expression, as if this is a classic papillary thyroid carcinoma. You know, this is what we see in those classic patterns.
Yeah. Hey, Frank, something in the liver? I mean, you get these roads like this often end up in your clinic. I see lots of false positives and stuff in the liver. Do we really see thyroid cancer metastatic to the liver?
You can. I mean, I would say when this started, this lady scared me from the beginning. So I kind of figured she's going to end up in my clinic someday. It's not common, but yes, it can happen.
So talk about that for half a second. Why did you think this one's coming to you just from day one?
Well, first of all, she shows up with this relatively aggressive, picture, radiology describes this. She has a lot of nodes. She already has pulmonary metastases. So we know that, yes, people can be cured with surgery and RAI, but the degree of bulk, I think, looking at this, I mean, it's interesting. Mark and their center has a study we're participating in, for patients neoadjuvantly with RET inhibitor, salpercatinib. So in looking at this lady from the beginning, I may have considered even looking at her NGS at that point to see if she would have qualified for something like that to participate. Not that there is a study with like lenvatinib up front, and that is not standard of care. I'm not necessarily advocating that either, but it just made me wonder, about these kinds of presentations. We know that in papillary, up to 50% can dedifferentiate, and there were comments already thrown around here. Is this more aggressive picture? Is this, could this be a, somewhat of a dedifferentiated, component that's starting to arise? Obviously, there's uptake with iodine, so at least that, favors a more differentiated component. But based on what I see here and the liver metastases against are rare, that this is a pretty aggressive tumor that eventually is going to come refractory to iodine.
So lots of red flags to everybody from radiology to pathology to surgery in this case. Amanda, take me a little bit more of the follow-up here.
Yeah. So here is some of the, she has this is the SPECT-CT images. And here is again the liver lesion and some of the small pulmonary nodules.
Azita, that liver lesion, thyroid, something else, can we tell from that single cut?
I think just seeing her initial study, did the lung lesions, are they new and they've enlarged since we saw her? It was 0.5 millimeters when you showed us the first image. The liver lesion, I see a solitary liver lesion. The lung that's what's concerning to me. And the second lesion that's more posterior in the lung, if you just look at the CT itself, you may think, oh, it's atelectasis, but it's really picking up FDGs, which makes me more suspicious that this is aggressive. The other thing that I failed to talk about with the initial imaging that I think we all failed is the thyroid on CT looked normal. I think that's, I only said that in retrospect. We were so concentrated on the nodes that we never talked about how there was nothing in the thyroid. There was no extrathyroidal extension. Nothing on CT would have told you this is from the thyroid except the location of the lymph nodes.
Yeah, that's awesome. And that's why when people always say papillary microcarcinoma never goes to lymph node metastasis, we don't think about this case like a papillary microcarcinoma, right? We ignored the entire thyroid. We're thinking about this as N1B disease, bulky disease. That's where they get lumped in there. What happened to her course, Amanda? Keep going for me.
So these are, this is her thyroglobulin, as you see, she went from 846 in November of 2019 to 7,000 at her last follow-up with me in December. So doubling time there is there to comment if you want.
And Erik, so we gave a dose of radioactive iodine in 2019. We got some uptake, maybe killed something, but clearly she's got residual disease here. What are you thinking about these thyroid globulins? How do you follow this?
I mean, it's a very robust number. It's continually going up. I mean, the doubling time thing tends to stem more from medullary and calcitonin, look at, but you can't help but notice here you're approaching 10,000. There's active disease. It's growing. I think if you go back a decade ago, we would always consider a second dose of radioiodine. More recently, though, there's so many new options, especially the neoadjuvant or the other just adjuvant therapy, that I certainly would involve my medical oncologist for thoughts on this.
Munir, should we be repeating radioactive iodine scans, or is she REI refractory at this point? How do you think about this one?
So if we do repeat it, I would make sure that we do the dosimetry as well, because this is precisely where we don't do dosimetry in every case, but this is clearly one of those instances where it'll be very useful, because while there are other treatment options, if we decide to pursue with the iodine treatment, we have to maximize the dose while also protecting the bone marrow and the lungs, especially since that uptake that you saw in the lungs, it was fairly blooming, even though it was a 6 millimeter nodule, it was a huge hotspot. So if it continues to express the iodine to the manner in which we saw in the initial post-therapy scan, then it may be worthwhile to maximize, but we need to do the dosimetry to make sure we can give the optimal dose.
Yeah, because we often get faced with heterogeneity, right? There's some that have done really well, and the stuff that's growing is FDG avid and not grabbing on very well. Structurally, Amanda, I'm sure you were following her. What she looked like structurally during this period?
So these are her last CT in August. She still has metastasis on the lungs enlarging. The initial CT scan was 5 millimeters. Now the largest pulmonary nodule is 11 millimeters, and it's the one that I'm pointing with my arrow there. And then she was found to have bone mets. So this one on the spine, on the far right, was radiated and was treated, but I just want to mention that this patient is trying to follow a holistic approach and does not want to be treated with an additional dose of radioactive iodine or tyrosine kinase inhibitors. So here's where we are, just watching this disease progressing. She's seen somebody actually in Mexico about how to approach this tumor with some sort of metabolic diet, and she gave me a book about that, and yeah.
We see this.
She feels very asymptomatic. She has always felt asymptomatic throughout this journey, so it's hard for her to be convinced that she has this widely invasive thyroid.
I get it, right? I mean, this is a 4-year history,
right?
That this panel all recognized on day one we might be here. Frank, if and when she decides to consider a systemic therapy, if we ignore those social things, how do you approach this? Because now, if they haven't seen you before, they're certainly seeing you now. Bisphosphonates, when do you start therapy? General stuff like that.
Yeah, that's a really good question. And what Amanda brings up, it just is not necessarily uncommon, because a lot of these people do feel fine. And some do seek, alternative, therapies. And, quite frankly, I don't say that necessarily is wrong when, people are feeling fine or they're not in any danger of compromise of an organ in particular. So, with this lady, I agree. I'd be concerned in particular if there was pain in her back to radiate that area. Bisphosphonate therapy to help support the spine. These people are at higher risk. I mean, she's getting, in her middle age in life that she's going to have compression fractures perhaps or pathologic fractures. So those things we would do. We would always tell the patients we would can improve mortality by about 15-20% if we suppress the TSH. And we're going to continue, to observe you if truly you're not interested in therapy now. Now, like I said from the beginning, knowing the lady's whole, story, and had she come to me and reviewing her whole story, I'd be more concerned that this is someone who needs to be followed more closely if we decided not to do therapy. So I wouldn't just say, let's come back in 6 or 8 months to a year to do CT scans. I would probably be doing scans of her chest, perhaps abdomen because of the liver involvement, and maybe spinal imaging probably every 3 months. And then certainly asking the patient to come back if she's developing, symptoms. The whole thing about therapy is always tricky. Yes, if someone shows up with bulky disease and they're very symptomatic, it's almost kind of like, a slam dunk. You probably really need, some kind of treatment to help A, potentially live longer, and B, to help relieve symptoms. And someone who has maybe isolated, lesions. So let's say she just had the bony lesion that's presented here. That we treat, with radiation, or surgery perhaps, and conservative measures. And it's always in the middle where we have to, like I said, watch these people. And if their disease is, the tempo is growing fast, we know the doubling time here is fast. Usually I've mentioned to these people, we're probably going to have to consider starting treatment with a TKI, sooner than later. So I try to prepare them for that. And again, it's a total discussion that you have to have each time that the patients come back. They are knowledgeable, they read, and they do know the potential side effects. It's interesting. We just published this Riftos paper saying that the median time to symptomatic progression is 55.5 months. And that's not necessarily when people started on TKIs because of just what was done here with, radiation and, observation of bisphosphonates. But interestingly, in another paper we just published, after that paper, looking at American versus overseas, the overseas doctors were more likely to start TKIs earlier than the American doctors. And interesting, when we did start them, the plateaus leveled off. But Americans negotiate everything. Overseas, I think people are more likely to say, you're the patient, I'm the doctor, you get treatment. So I don't know. The question is, when is the right time? And I don't know that we've fully defined that yet, and we're still learning.
So 2 quick questions before we finish this one. Munir, there was a question about Amanda gave 150, would have 200, if you knew it was a BRAF V160, would you have given 200 or a different dose, or how do you sort of think about that?
Yeah, so if I had known that it was BRAF, then in that case, I would have done the dosimetry at the first go, and then see if I can maximize, knowing that even though they may have iodine expression, their response rates are going to be questionable. So maximizing the impact of the very first go would be very important. The other important point I would like to bring up here is that when we see the patients for consults, and when there's a big discordance between their symptoms and the extent of disease, oftentimes showing the images to really emphasize not only the total burden, but also some sensitive sites such as risk for compression fractures, it actually does make a difference in trying to convince them towards agreeing to get the therapy rather than saying, oh, I don't have any symptoms, why do I need the treatment?
Yeah. David Pfister taught me that years ago. Also taught me to ask the patient if they wanted to see it before I showed them, because every once in a while somebody says no, they don't want to see it.
No, you're right. Yeah.
And then the last question on this one, there was a question about the solitary mass in the liver. Could you do radio frequency or some? So yes, we will deal with focal lesions that are enlarging, just like they did with the spine, to radiate that. So I've never done RFA, but that's sort of evolving now. We've done radiation, we've done surgery. So if there was one place outstripping everything else and we weren't going to do a systemic therapy, that's something we'd consider. Okay. All right. So good case. Amanda, let's go to your next one.
Okay. Okay, so this is a 79-year-old woman who was first diagnosed with a toxic multinodular goiter at age 63. And at that time, she was treated with 29 milligrams of iodine 131. And she remained euthyroid for about 16 years without needing levothyroxine or methimazole or anything. She comes to us with recurrent hyperthyroidism with a TSH that is suppressed as less than 0.01, an elevated free T4 of 2.07, and a total T3 elevated at 245 nanograms per deciliter. And on exam, she had a firm and fixed 2 to 3 centimeter left thyroid nodule with no palpable cervical lymphadenopathy.
Okay, so let's show Dr. Ghesani we got to do a radioactive iodine scan. Holy
So
cow.
here's the thyroid scintigraphy here when she presents again with recurrent hyperthyroidism.
Can you make sense out of this, Munir? Just a snapshot here.
Yeah, so what's happening here is that, what really helps is that upper left corner image that has those markers. It's called anterior markers. So, one is at the sternal notch, the other one is at the, what we call in the base of the neck, under the mandible. And so that gives us the idea of where exactly is the extent of uptake. And you can see, first of all, that there's no uptake whatsoever on the right of midline. And that's because presumably that's a completely normal thyroid gland that has been suppressed as a result of the hyperfunctioning nodule on the left side through the inhibition circuit through the TSH. And then on the left side, there is in the mid pole, there's focus of increased uptake that is best seen on the right lower column, the LAO, left anterior oblique image. You can see that oval hotspot is probably the most significant culprit hyperfunctioning nodule. But surrounding that, there are cold spots. So the entire left gland is not normal. Otherwise, they would have suppressed because of the hyperfunctioning nodules. I would suspect that there's probably an element of Hashimoto's thyroiditis throughout the left lobe. And there are some non-functioning nodules in addition to the dominant hyperfunctioning nodule.
Fantastic. Amanda?
Okay. So here's the report of the study, heterogeneous uptake in a hyperfunctioning left thyroid nodule with suppression of the contralateral lobe, which is exactly what he just informed us. And this is the neck ultrasound that we obtained for this patient.
Dr. Alexander? We're headed down. We got to figure out what to do with this little nodule thing here. It looks like a nodule to me. Stick a needle into it, watch it. It's a hyperfunctional nodule. We don't trust Dr. LaGreca, so we know something's going on. What are you thinking, Erik?
I mean, generally, when we have functional nodules, we like to think that they're benign processes, which usually is the case. Having said that, I mean, this is not your case of an exact solitary functional adenoma and a singular easy thing to see on the scan. There is some heterogeneity here, but I think as was described, this probably in the lower bed of the thyroid does correlate to that area of increased uptake. I can't say I would rush to do a biopsy on each one of these after that scan, though I'm nervous when something's being presented here.
Amanda, help me with the logic here. So you can go ahead and show the biopsy. You did the biopsy, but what was the logic to head down a biopsy pathway here?
I guess we didn't like the look of this deep hypoechoic nodule, taller than wide, and we were thinking it's hard, but it's firm on palpation. It looks suspicious on ultrasound, and I think we're gonna go for a biopsy just to make sure that we're not dealing with that rare exception of.
So as opposed to the usual hot nodule that looked benign to you that you wouldn't stick a needle into, there were some worrisome features about this that took you down this pathway, right? So this is the exception to biopsying a functional nodule rather than right. Okay.
The only thing I'd add, Mike, is after she had received one dose of radioiodine 15 years ago, and nodules can involute and look a little ugly over time, and so that could also explain it. Though I certainly don't I don't doubt the reason why we would biopsy based on what was said.
Yeah, it's not like it's a virgin gland that's never seen anything. Okay, Amanda, let's see what a helpful.
So then here is the FNA of the left thyroid nodule.
Zubair, lots of purple. That's I don't charge for that. That's free.
Yeah, so I mean, on the left-hand side, on my screen, it is a cellular specimen, which is expected from functioning nodules. So whenever you put a needle, because they are, kind of adenomas, so they are neoplasms, they're clonality. So you're going to get a lot of cells, which we are seeing. It does have that purplish background, which is also reminiscent of watery colloid, which we always think of that most likely you'll see that in benign nodules. Now, on the right-hand side, where there's a higher power, you see all the red blood cells are kind of sticking together, which is the rouleau formation, because there's a protein in the background, which is from the colloid. Now, interestingly, if you look at those cell groups, there's these really dark purplish pink tiny spots at the periphery of it. And that has been called in cytology as fire flares. And when you see that, you're thinking most likely you see them in hyperplastic or adenomatous or hyperfunctioning nodules. So that has been described in the blood. You can also see them in tumors. And I can see why this, will generate a diagnosis of this based upon cellularity. The cells look very same, and even you can see that they look very similar to each other. There are no nuclear features of papillary carcinoma in this. So, so most likely that will be pushed into the Bethesda category 3.
So Zubair, there was a question on the question and answer session that says, any idea what an FNA looks like after somebody's had radioactive iodine of a hot nodule?
So what happens is you may not get a lot of cells if that nodule has undergone fibrosis. Plus, the radioactive iodine sometimes causes really marked atypia of the cells. So you may see 1 or 2 very atypical cells. So that history really helps to say that this is within the realm of the treatment effect, and I'm not going to push it and call it something horrible. So that history always helps.
Okay. And Amanda, how did your team read this?
So this was exactly, a category 3 atypical cells of undetermined significance. And we, of course, send this sample for molecular markers.
So thank God I got to see the slides last night so I could look up GNAS, so I didn't look too silly this morning. But Erik, since you do this molecular testing, tell me, any idea about what the heck is this GNAS thing?
I mean, I think this is the complexity of broad-based panels, is we don't always know what each of these mutations is, but certainly GNAS is not a widely seen a mutation in florid malignant processes, at least that I'm aware of. And so I'd probably look it up like you did and try and just get a little understanding. But the report here, of course, is that this is rated as a low-risk mutation.
And Zubair, they tend to be, this GNAS signals through TSH receptor, if I'm reading right.
Yes, yeah, and this also showing you the high expression of sodium iodide importer. Now, interestingly, the GNAS mutations have been described in tumors which arise carcinomas, thyroid carcinomas. At least I know 6 or 7 has been reported in patients who have the McCune-Albright syndrome, because that is the one, GNAS is the one which is the hotspot for that. So interestingly, when you look at the TSH receptor and high expression of NIS, most of the tumors which have TSH receptor and are carcinomas have associated mutations like BRAF or RAS or EZH1. In our cohort that we published, we had only 1 case of carcinoma, and that was the only case that had a very high expression of sodium iodide importer. But this combination, naturally, you're thinking more of a autonomously functioning nodule, so very low risk.
So you got a hyperfunctioning nodule, you got a GNAS mutation. So you go, cool, this should be hyperfunctioning nodule. And I assume just treated for thyroid toxicosis, Amanda?
Right. So this is what we did. We talked to her and we said, well, I think you're having a benign nodule. And like Dr. Alexander said, this is probably looks, suspicious because you got radioactive iodine so many years ago and it looks abnormal. But we biopsy, we send that to Thyroseq, it's benign. So we said, okay, start treatment with methimazole, and we will repeat. She repeats an echo ultrasound in 1 year.
And she lives happily ever after, and that's the case you presented to us.
So now she's 80 and she gets this ultrasound. And I'm showing pictures of the left lateral neck because this is a new suspicious finding there.
This is Erik, can you see this one, or Azita? I don't know. So
yes, I can
Azita?
talk about it. So on the top left, I'm doing radiology versus everybody else. If you look at it, there's a well-defined echogenic soft tissue posterior to the strap, but next to that is the carotid. So that's how you know that's the jugular vein. Am I making sense? So you're supposed to have carotid and a jugular vein. You're supposed to have flow in them, while the jugular vein is echogenic. And then at the bottom right, when they show the long image, it looks like the entirety of the length of the jugular vein, there is an echogenic mass in it. Am I,
Yeah, you're perfectly right. Mark,
You're right.
this makes zero sense to me. It's 1.5 centimeter, and they're going to try to tell me this is a tumor growing into the jugular vein. Is that possible or even reasonable?
Absolutely. Yeah, we see it, with angioinvasive tumors, particularly, follicular thyroid cancers or Hürthle cell carcinomas. I mean, rarely some follicular variant of papillary thyroid cancer. Follicular variant of papillary thyroid cancers can also be angioinvasive. So certainly could be one of these tumors, follicular or Hürthle cell, most likely with these sort of angioinvasive tendencies. And they not only get into the minor vessels, but sometimes they get into the major vessels too, and they track along the minor vessels, and eventually they get into one of the major vessels, like the jugular vein.
And assuming you do CT scans or whatever else you do to confirm this is in the vein, your surgery would be what, Mark?
Well, in this case, I mean, you have to consider the context. This patient's already had a total thyroidectomy. I probably, I'm going to assume that we're probably not going to get much more information from the pathology. One thing I probably would do, though, is get a PET, just to sort of, now that we're thinking, okay, this is an invasive thyroid cancer, patient's had previous surgery, I may just kind of get a PET just to kind of see what the landscape of the neck looks like, make sure there's not any distant disease. But other than that, it would just be a focal revision surgery on the left side, removing this residual thyroid that now has invaded the jugular vein. Sometimes this requires sacrifice of the jugular vein. Occasionally, we can do a thrombectomy of the jugular vein. If it's just sort of slight tumor invasion there, you can cut, make an incision in the jugular vein, take out the thrombus, and then sew the jugular vein back up. I mean, I think if it's a small thrombus, I would try to do that, and then save the jugular vein that way. But ultimately, if you have to sacrifice the jugular vein, it's not a huge deal. The patient probably won't have much sequelae of that.
All right, Amanda, what was this thing? We went to surgery, and what'd you take out?
So she, okay, this is what we just said. There's a tumor invasion into the vein, and it's described as a tumor thrombus. And she goes for a left thyroid lobectomy, and this is the surgical pathology report slides, if you want to describe those.
We went from purple to pink. Back to you.
Yeah, so I mean, I don't know if there's not a normal thyroid, but I think that on the left side, it almost looks like a vessel, something which has this giant tumor in it. It does look pink, so it looks more like an oncocytic type of tumor. It's not papillary for what I'm looking at. It doesn't have those nuclei. So I don't know what this section is from, but it is all tumor at this point, and it looks more of what is called as oncocytic carcinoma. I don't see any necrosis and mitosis at this point, but maybe on the top right, on the big, there's a little pink stuff. So I will be worried that it's more like a high gradish, but at this point, it just looks like an oncocytic neoplasm. So I don't know what this section is supposed to be. Is it like a thrombus in the vessel, or?
I think so. So
This
Amanda,
is, yeah.
next slide, show the path
Right.
report there.
So this is the surgical path report, and this is before this changed to oncocytic cell carcinoma, the name. It was informed Hürthle cell carcinoma with tumor thrombus on a vessel.
Okay, Munir, I don't understand this at all. Hürthle cell cancers are not supposed to concentrate radioactive iodine, and Amanda's trying to sell me one that's hyperfunctional with a GNAS mutation. What are you thinking here?
So the key word here was that ultrasound said that there's a new nodule. And if we had repeated the thyroid scan after that nodule was discovered on the ultrasound, and we have now a landmark of previous sites of where the nodules were, both hyperfunctioning and hypofunctioning. And if we saw another core nodule now on the follow-up, then we know that if that's the nodule that actually is not trapping any iodine, and that would make more sense, because otherwise it would be scary that every single hyperfunctioning nodule we have to think about a Hürthle cell. Yes, there are some reports of low-grade cancers that can be seen, as Zubair just mentioned the examples. So, some of them, potentially GNAS mutations might be responsible for the cohort that he described for maybe a minority of those. But to have a Hürthle cell cancer that is hyperfunctioning would be fairly scary because it would change our practice paradigm. But I suspect that it was a new nodule and that probably was a cold nodule.
Amanda, how did you guys put this one together?
So this is very rare indeed, and there are maybe 1 or 2 case reports of hyperfunctioning Hürthle cell carcinoma. So we do believe this is a hyperfunctioning Hürthle cell carcinoma. I think we were puzzled because that sample was sent to Thyroseq and they did have enough material to analyze it. And the reason, I even called Yuri about this case, and he believes maybe we sampled a site that had no malignant cells and a lot of hyperfunctioning that obscure the whole result.
Yeah.
And the limitations that Thyroseq has for Hürthle cell carcinomas.
Yeah.
So it was a surprising thing for us too.
The rest of Thyroseq also didn't look like a Hürthle cell carcinoma.
Exactly.
Right? So I think Munir's, that goes along with Munir's thought that what's hyperfunctional probably was not what was invading into this vessel in all likelihood. Okay, good. All right, that's a great one. All right, let's do one more, and I want to focus on mainly the end of this one, which is the systemic therapy. All right.
So she's a 62-year-old woman. She presents with an rapidly enlarging left neck mass. She denied any symptoms. No trouble swallowing, no difficulties with her voice. And she gets an ultrasound. This is her first imaging at an outside facility and shows this large left thyroid nodule.
Keep going.
Okay. So then this is the report: left solid node measuring 3.3 centimeters, TRADS 5, no suspicious cervical lymphadenopathy. So she gets FNA of that nodule, which is reported as malignant cells present, favors anaplastic thyroid carcinoma.
Hey, Zubair, this comes up a lot. When we're dealing with anaplastic, we need to make the diagnosis quick. We need a quick BRAF. We've seen the rare case now that was called anaplastic. It turned out to be lymphoma when it was all said and done. So the role of FNA versus core, trying to make that balance between I need to know as quickly as possible. What would you favor here?
So we are starting with something that morphologically looks malignant. It looks bad and it looks malignant. So naturally, if you're thinking of anaplastic thyroid carcinoma, and not all the cases are amenable to the cores because where that mass is sitting and how vascular it is and all that stuff. And if the radiologist or the surgeon is not comfortable at that time to do a core. So I always ask them to do multiple passes so we can get a good cell block. Once you have a cell block, then, because it's also, you have to prove that this is anaplastic carcinoma and it's a thyroid primary. So you can do a few stains plus, and if they are positive, like Paxate or TTF1 in some cases, plus sometimes, as you know, some anaplastic carcinoma doesn't even have keratin. They even lose their keratin profile. So I think it's basically more of a triage at that point that you're getting an enough sample. And if cytology is not good enough because some anaplastic carcinomas have a lot of fibrotic tissue, you're not getting cells, then the core in those cases is very helpful to get. And then, you're using an 18 gauge and you can do immunos and further studies on it.
Mark, you guys have sort of perfected this rapid diagnosis, treatment, triage of anaplastic cancer. What do you guys do for the diagnosis? Liquid, FNA, core, practicality. How do you do that, Mark?
So thank you for the question. For this case, we would probably do a core in this case to give us the best shot at the most tissue in a rapid fashion. Obviously, sometimes you can get as Dr. Baloch was saying, you can get the results just from a cell block. But I think sometimes just to be fast, we will get a core with it as well, just so we don't have to go back a second time if there's any issue with the specimen. So yeah, and then with that specimen, we would do immediate BRAF, D600E immunohistochemistry. and also at the same time send next generation sequencing for mutations and fusions. But, as we all know, that next generation sequencing may take, a week, 2 weeks to come back. So first, we're sort of looking at the BRAF status. Then we're sort of waiting on the next generation sequencing. We also do typically send a liquid biopsy as well. And those results typically take a week to come back. That's sort of redundant with the next generation sequencing, but the reason that we send that is because sometimes, or most of the time, the liquid biopsy comes back at about a week, and the next generation sequencing comes back at about 2 weeks. So it's a little bit faster.
Okay. So Amanda, show me her staging and then the molecular testing, and then we'll pause for a second and talk there.
So here's her staging. A chest CT scan showing pulmonary nodules. I think they were 10 to 12 millimeters each. Then she had a neck CT, and we can all see the mass
And
there.
Azita, what am I looking at there?
Well, the CT of a chest shows this matted soft tissue in not only the thyroid bed, but also in the left neck. It's without contrast, so it's difficult to appreciate, but I think if you look at it laterally, it's inseparable from the left common carotid and jugular vein, and it's a little flattening of that the tracheal wall is a little flattened. So you always have to worry if there's tracheal invasion. That's sort of what worries me. Yes, right. Lateral on the left. And then plus the pulmonary nodules.
Perfect. And the Munir, the PET scan, you peek at that?
Yeah, so given the anaplastic, it does have a high degree of FDG expression, both in the left neck mass as well as in the lung nodules. Also, I see that there's a right paratracheal node stationed. We don't have the CT of that corresponding site, but I am suspecting that in addition to the multiple metastatic lung lesions, patient has a mediastinal metastatic lymphadenopathy as well.
Okay. And Amanda, we happen to know her molecular testing?
Yeah, so this is what we did. We do exactly what Mark described. Pretty much, we send the BRAF within 24 hours, and then we send the next generation sequencing panel, and this is what we got.
And Frank, help me with this. What does this mean? How does that change what we're doing? What are you thinking here?
Yeah, so we would do the same thing that everybody else would do. So, a few thoughts here. So she has, or the patient has a RET, fusion. So we now have selpercatinib is FDA approved. Pralsetinib was taken off the market. So we have one direct RET inhibitor. So that would be the first step in treating this patient, would be to treat with a targeted therapy. It's interesting regarding that. It's with the BRAF positive disease. I've seen a lot of, very good, rapid responses. I have with this, but this can be very variable. I have some people with these RET fusions or NTRK fusions who do beautifully. And then I have some that for some reason they may quickly respond, but then the response is not quite as durable. What would be important here too would be the addition of immunotherapy. So there's a high mutational burden, DNA mismatch repair, and a lot of these anaplastics. You can thank me for this. I went to the NCCN and pushed to have immunotherapy put on the guidelines. It is under special circumstances, both nivolumab and pembrolizumab. So that was a big problem, unless they were on a clinical study like we would do, with the Anderson group, if it was BRAF positive, with treatment up front, surgery, radiation, pembro, and then DT plus pembro. But in this case, I would definitely start with selpercatinib. I would now petition to get immunotherapy to treat, because I think you could potentially have a very nice response systemically from both agents, and then consider surgery, followed by radiation and other adjuvant therapy.
Now, Mark, you usually don't know the RET mutational status before surgery because this is moving fairly quickly and you're doing surgery. But assume you did, that you knew this. We haven't done surgery yet. She's got distant mets. What's the sequence here? Do you try neoadjuvant? Do you do surgery first and then give the systemic therapy? Not a lot of data here, but how are you thinking about this, Mark?
I think it's a great question, and you brought up the controversy there. I think if we were looking to do this surgery quickly, and we saw that the tumor is technically resectable in the neck, it was difficult to tell from that one image. But if we saw that it was technically resectable, you know, meaning that we thought we could get it off the carotid artery, most importantly, based on that image, we could consider just a quick surgery. I mean, that obviously, you know, requires getting the patient into surgery within, you know, a week or so, which can be challenging in some places, just due to OR scheduling. But we do it when we have anaplastic thyroid cancers that are resectable. I think if we knew the RET results, we would treat this patient in a neoadjuvant fashion. So these are so rare that it's certainly understandable that one may not wait for the RET fusion result. But if the patient, as is shown here, does have a RET fusion, we haven't done surgery, we would start the patient on a neoadjuvant approach with, just as Frank mentioned, a RET inhibitor plus immunotherapy, given the patient has extrathyroidal extension and the patient has distant metastasis. And so I think getting that patient on upfront systemic therapy as soon as possible is probably is what we're the way we would go with it.
Got it. Amanda, show me the path report, then I'm going to come to Frank for sort of next steps.
Sure. So she did not get neo, and this is 2 years ago. So she got a total thyroidectomy and a central neck dissection, and the path report confirmed a 3.5 centimeter anaplastic thyrocarcinoma with small component of PTC. She had gross extrathyroid extension into the muscles with focally positive margins, extensive lymphovascular invasions, and 3 out of the 10 central neck nodes with metastatic ATC 9 millimeters with no external extension.
So Frank, if she didn't have distant metastasis, I assume we would probably be going for external beam radiation because there was gross extrathyroid extension. In the setting of distant metastasis, how do I do radiation and then selpercatinib together? Where are you on that now, Frank?
Yeah, so what I would do in this case, assuming she has what she has with distant metastasis, well, first of all, if there wasn't anything there, yes, I do external beam radiation therapy, and they probably would have observed the patient. But in this case, there's distant mets there. Again, back to the whole immunotherapy story that, you know, Mark and I both kind of brought up. I actually would start immunotherapy in addition to radiation therapy. The reason being is that you can get kind of more bang for your buck. Immunotherapy or checkpoint inhibitors aren't radiation sensitizers, so you're not going to get an advantage of you know, making the radiation stronger or even causing more toxicity in that case. But it will treat the systemic disease. I would not give selpercatinib in combination with radiation because of the concern for radiation sensitization there. So what would happen in this particular case, we would do pembro with radiation. Once the radiation's finished, we would go ahead and you know, reassess imaging, but probably start up selpercatinib and continue the immunotherapy.
Perfect. And Amanda, you put her on selpercatinib. Show the response that she had.
So here's the starting of the treatment. This is 20. We started this, and the 2-month treatment is the picture on the right. So these 2 pulmonary nodules almost resolved, even this area here. So this is 2 months into selpercatinib. Perfect.
And then you've got one more longer term.
Yeah, and then this is 20 months of treatment with selpercatinib. This is the largest pulmonary nodule that we could see, which is, I think, 4 or 5 millimeters, and there's no disease on her neck. I didn't put a picture because it was no evidence of disease on her neck.
So Frank, in 30 seconds, selpercatinib clearly working here. This has changed the natural history of anaplastic.
Yes, yes. And like I said, this is a lady who has had a remarkable response. And I have seen this too. I have another gentleman very similar to this case. Very, very similar. So yeah, no, this is great. Again, we don't necessarily know how these are going to behave. Again, I'd probably consider, because immunotherapy is available, to add that in addition way back when. But nonetheless, selpercatinib here is doing the trick. So we would continue the treatment just as you are doing until any side effects or the patients really can't, you know, tolerate treatments, or, you know, perhaps if they need a break, we could consider a break at some point in time as well.
Fantastic. We're right up at the hour. Dr. LaGreca, thank you for some wonderful cases. Panelists, thanks for thinking through these. These are unusual cases, but wonderful to think about. We look forward to everybody coming back for next week's our weekly Tyro and our monthly tumor board. Thanks to all. Bye-bye.
Thank you all.
Thank you. Bye.